would like to begin in a good way and acknowledge and respect the Lekwungen song. He's Kosepsum Esquimalt peoples on whose territory the university stands, and the Lekwungen and Wasanich peoples whose historical relationships with the land continue to this day. I think we're so fortunate to live and play on the island. Today, I'm actually joining from unceded territory of the Anishinaabe people, but Victoria is in my heart. And I have the pleasure of introducing today's speaker. Dr. Craig Kuziemsky is the Associate Vice President Research at MacEwan University in Edmonton, Alberta. He earned his PhD in 2006 at the University of Victoria in our School of Health Information Science. From 2007 to 2019, Dr. Kuziemsky was in the Telfer School of Management at the University of Ottawa, where he held both academic and administrative positions. And from 2016 to 2019, he was the inaugural University of Ottawa Research Chair in Healthcare Innovation. His research focuses on systems thinking approaches to health system transformation, including the design and evaluation of digital health tools. He's a fellow of the International Academy of Health Sciences Informatics and also at the American College of Medical Informatics. He's currently an adjunct with us in HINF and also at the Telfer School of Management at the University of Ottawa and at the University of Aalborg. And so that I don't take up too much of his time, it's a pleasure to have Craig, and a warm welcome to hear more about the systems perspective on digital health maturity. Thank you so much for being here.
Thank you very much, Ellen. And I'll make sure I do thank Dr. Courtney for the invitation to do a seminar. As Ellen said, I did my PhD in health information science, so I always kind of think of you, Vic, and HINF as home. So it's nice to be home in some ways, albeit virtually. So I'm from Edmonton, Alberta, at MacEwan University, as Helen said. So I am on Treaty 6 territory in Edmonton. It is the traditional gathering place for many Indigenous people, and we honor and respect the history, languages, ceremonies, and the culture of the First Nations, Métis, and Inuit that call Treaty 6 territory home. So what I'm going to talk about today is a systems perspective on digital health maturity. And I had a talk kind of laid out. I liked the way Morgan did his talk last week. So I actually went back and did a little bit of restructuring, but I'm going to go through 5 things. I'm going to start with some terminology because I always like to start talks making sure everybody's on the same page with respect to language, because some of the terms that I'll use can probably have different interpretations. I'll talk a little bit about digital health maturity. That's what DHM stands for. Just as a systems of systems, a little bit about what systems thinking is, why it's beneficial. I'll then talk a bit about how do we kind of integrate or use systems thinking to try and enhance digital health maturity. I'll give you a couple of examples from some of the research that I've done in collaborative care delivery and artificial intelligence. And then I've got a lot of time left for discussion at the end, because I really hope to kind of have a really good two-way conversation with the audience. If people want to put their questions in chats, I'm happy to take questions as the talk goes along as well. So you don't have to wait until the end. All right, so let's pretend we're having a fictitious conversation. We've got 2 people. Gentleman on the left says, why can't I access my health records as easily as my banking data? The very smart person on the right, probably studied at HINF, says the digital maturity factor is different. Now, the gentleman on the left will have no way of actually knowing what the digital maturity factor is, but that's what I'm going to try and get across today. I'm going to talk about digital health maturity, again, as outlined in the introduction, through a few different perspectives. And even though I'm using the term digital health maturity, and I'll define it in a couple of slides, it's a newer term, but the spirit of it has really been around for decades. And hopefully, as you watch what I present, you'll probably resonate with a little bit and you say, hey, wow, I've kind of been doing elements of digital health maturity, and I didn't actually know it. A lot of what I'm pulling from, and this was kind of when Karen reached out to me for the invitation, she had seen a book chapter that I wrote in a book that Sutang Lau and some colleagues co-edited last year. It's called Digital Health Maturity, Quality, Interoperability, and Innovation. I've got one chapter in the book, but a lot of what I'm going to talk about pulls from many of the chapters in the book, certainly the first five, and then I think my chapter is seven or eight, if I remember right. That's where the majority of the content comes from. But if you find it interesting, you want to learn more about just some of the background and some of the applications of digital health maturity, this is a really good book that you may want to take a look at. All right. So as I said, even though digital health maturity as a concept is a bit newer, like I said, the spirit of it's been around for a long time. And this is a paper that I still cite to this day because I think it really characterizes what digital health maturity is about. So Clem McDonald, Mark Overidge, Bill Turney, and a few others, wrote a paper saying that implementing health information technology is a journey and not a destination. And that really sums up what digital health maturity is. It's a journey. It's something that we strive to do it. We want to be more mature with respect to how we use digital health technology, digital systems, but it's not really anything that we get to like a destination. It's something that we're almost always constantly trying to refresh, revise. And I think that really speaks to the spirit of it really well. So if we get into a little bit of the terminology, there's varying definitions of digital health maturity. I pulled a lot of this out of Tang's book, but it refers to, any agent's readiness, progress, effectiveness in adopting digital health interventions across different stages of maturation. And I highlighted in red what I think the two key words are. It's progress, because again, it's not something that we just do and we stop. We're almost always revising it. And it happens over stages. So maturity, we can go from a more immature product to a mature product. Again, that doesn't happen overnight. Sometimes it takes, months or years, and it happens over stages. And one of the key things to remember is that we're talking about maturation of a user's skill set, clinical processes. It can be maturation around policy and things like that. We're not talking about maturation of like the actual technical product. So the electronic medical record, the chatbot, the CPOE system, whatever you're working with. So that's an important distinction to remember. And even though DHM is a bit of a newer concept, it's been studied in a lot of different contexts. People have studied it around communication systems, hospital information systems. Tang's done a lot of really good work in the South Pacific because he's based out of Australia, in low middle income countries. So there's a pretty good body of evidence out there about how it can be used. And aside from just studies of how it can be applied to digital health implementation, there's also a lot of models and frameworks. And I'm actually going to talk about a couple of the models towards the latter part of the talk that draw out of Tang's book. And, as I said, really, the main takeaway is that maturity develops over a life cycle over time. It isn't kind of something we do and we're finished, we stop. History can tell us a lot. And even though, as I said, digital health maturity is a newer term, if you look back at, I think, some of the really seminal medical informatics studies, they actually talked about a lot of the things that you'll see, if you take a look through Tang's book, or if you read through any modern current papers on digital health management. So, in 1997, it must have been going around that year, both Joe Nash and Bonnie Kaplan put out really good papers on implementing health information systems. And they said, look, there's numerous considerations, there's numerous things that change, the people change, the information system changes, the organizational dynamics change. And they didn't call it digital health maturity because I don't really think it was probably a term back then, but that's what they're referring to. They're saying as you put health information systems in a setting, things happen and things keep happening and things keep happening. And that's digital health maturity. In the same way, Nancy Lorenzi had a paper out in 2003, talking about change management, how we move people from the old to the new. And again, Nancy didn't call it digital health maturity, but she was really referring to the spirit of it. That's essentially what it is. So, a lot of the historical work, this is just, a very small sample of it, can actually tell us a lot about some of the things that we're trying to do today. So, good literature reviews are always they're always your friend. A topic that I've done a lot of research on, I've done less lately, but I did a lot just kind of when I became a faculty member, kind of out of my postdoc, is on common ground. Common ground came out of the communication literature, and it basically refers to the shared knowledge that two or more agents need to have a conversation. So if Helen and I are going to have a conversation, I can converse with her fairly easily because I know her background, I know what she researches in, I know a little bit about her. It makes it easier for us to have a conversation. In the same way, if you're trying to have a conversation with people you don't know, you've got less common ground. It makes the conversation different. And if we think about that from a digital health implementation or health information technology implementation, that type of knowledge can help us when we implement technology, because as we implement technology to automate a task, knowing about the users, knowing how they use information, how they think about it, how they process it, can help us to understand, how we can ideally design the technology to support what they need. And it's no surprise that the common ground topic's been applied in medical informatics research quite a bit. Enrico Carrera did really some of the first work on it, 26 years ago. And he was interested in trying to understand when you needed to talk to people as opposed to when you could rely on um, health information technology to try and get the answer to a problem or to try and facilitate a conversation. Because really his hypothesis was if you've got lower groundings, you don't know a lot about a situation or about a person, you probably want to talk to them in person because the technology may not be able to facilitate the conversation as well. And then kind of picking up on Enrico's work, Morten Hertzum in Denmark has done some work on it. I've done a lot of work on it. Sarah Collins from Columbia has done a lot of work on it, largely around interface design. So how do we design an interface for a clinical or other information system that can best help people do what they need to do? And then the work that I did, just really briefly, I tried to kind of pick up where Enrico left off, because he said sometimes you need a computer, sometimes you need people. I was really more interested in how Common Ground developed because we didn't really know a lot about it, 10, 15 years ago. So a lot of my early work was on how it actually develops. What are the factors that help it to develop? What are things that prevent it from developing? Are there certain times, certain moments when Common Ground is more important than others? And, not surprising, we found that context is an important influence on it. It's got individual and group components. So you're trying to mediate something for a collective, but a collective is the sum of individuals, and how individuals move into the collective isn't always done well. And I think sometimes people think team-based care delivery is I can do the same thing I did as an individual. I just do it in a team. It's like, well, no, like you have to change things to work in a group. That's a bit of a struggle. And I think the key message really about Common Ground, just certainly from my work, is that the behavioral developments, how people kind of behave with the system, how they use it, it occurs over time, it occurs in stages, and there's always a development cost. And I think you have to think about, is the juice worth the squeeze, or is the cost worth bearing? And then just some work that Dr. Tracy O'Sullivan and I did at the University of Ottawa 10 or so years ago. We looked at Common Ground more from a public health, from a disaster and community response perspective. And what we came up with, I tried to circle it in red, hoping you can see it. The main findings that we had was that when you put people together, they need to coordinate what they do. And coordination takes time. Once people got comfortable coordinating with each other, they then moved into cooperation. And through cooperation, that's when you start developing trust, shared rules, factors like that. And then only then can people actually get into collaboration because they've got sufficient trust in order to exchange information, put the trust in someone else if they're making a decision, things like that. So again, I think the main finding from our work was that these things happen over time, and you kind of really have to start by getting people to coordinate what they do if you down the road want to get them to actually collaborate together. Also related to digital health maturity is the concept of learning health systems. There's a lot of papers out there. Chuck Friedman from University of Michigan started a journal on it a few years back, just basically referring to the data, the outcomes that we need to collect to try to make sure we're understanding how a system evolves over time And not surprising, we've seen a lot on learning health systems lately. There's been a lot coming out about just workforce development, artificial intelligence, and again, it really speaks to the flavor of digital health maturity because it's about trying to understand how a system functions at a moment in time, but also what does the data tell us about what we need to do to try to improve it. So if we kind of summarize just the background a bit, okay, we've got digital health maturity. So it's a newer term. And as I said, it mainly refers to the development of competencies, refers to the development of processes, recognizing this can happen over the micro, meso, and the macro spectrum of where digital health gets used. So, even though we may be thinking about the micro in the study we're doing, we do need to remember that, processes, policies from health systems, privacy policies, which a lot of times come from the government, funding models, which come from the government, those can all influence digital health maturity. And just, I was trying to think about what ways of studying digital health um, could I relate to digital health maturity? And this is by no means an encompassing list. As I said in the introduction, change management, common ground, learning health systems, social and organizational issues, scale up, system development life cycles, methodologies like participatory design, these really all have aspects of digital health maturity in it. The usability work that Elizabeth Bricky and Andre Kushnerek work on, usability doesn't happen in an instant. It's got a development piece to it. All of that you could say is kind of part of us doing research, trying to understand digital health maturity. All right, so with that background, I'm just going to give you a really brief introduction to digital health maturity as a system of systems. Apology to those who have seen previous talks of mine on health systems, because you may recognize some of the slides. I know Helen's seen this one before. So systems thinking is the introduction sort of mentioned, the main area that I'm doing work in today. And this basically shows what systems thinking is. It looks at health systems as a set of interacting concepts, and it doesn't really pay attention to any individual one, but rather the focus is how the various concepts interact over time. And again, this is by no means all inclusive. I created, circles for clinical, policy, technical, socio-technical, social and organizational. And if you think about a health system, what systems thinking tries to imply is that as these concepts move around, sometimes I say they're like balloons. You let balloons go, they kind of bang into each other, and you always end up with a different visualization of them. I use a billiard ball analogy sometimes. You hit the white ball into the billiard balls, they move. You hit them again, they move again. That's really what a health system looks like. These things are constantly moving around. And as you change the technical part of a system, or you change a policy, or you change the data we collect, it'll impact the other parts of a system. Sometimes they're small changes, they don't make a big difference. Sometimes they're substantial changes, they make a big difference. And even small differences over time can kind of piece together and make a bigger difference. And as I just said, if we think about implementing digital health tools, digital health approaches, is a system of systems, the main takeaway is that it doesn't focus on any one component, but really it tries to understand, tries to visualize, just tries to think about how all those different components bang into each other and kind of what the reconfigured system looks like after all the changes happen. And where systems thinking becomes helpful is that it allows us to visualize, the impact of changes on a system, but it also helps us to understand, what competencies do end users need to develop in order to, best work in a new system. It also helps us to understand things like trade-offs, because a lot of times we change a policy or we change data, that will require people to do things differently. People don't like to do things differently, and I find just from the studies I've done, sometimes it's almost like a negotiation. Okay, if you give us these two new things, you can keep this one old thing. And you end up with a bit of a negotiation. That's what I call trade-offs. You almost always have to give something up in order to get new things. But you have to be careful on how you do that. All right. This is a bit of a question. So if anybody has thoughts on this, I would welcome comments in the chat. I'd welcome comments at the end. Andre Picard had a column in the Globe and Mail, and I think he had a webinar, a meeting on CBC where he was talking about this. His hypothesis is that the principal problem that healthcare systems have in Canada, and this refers to a lot of things: wait times, access, interoperability, kind of all those things. He says it's a lack of implementation. So he says we don't have a healthcare crisis, but we have an implementation crisis. I understand his perspective, but I don't really agree with him because that kind of implies that all of the things that plague the healthcare system, and I mean, if we decided to do a webinar on all the problems our healthcare systems have, Alberta's not any better than BC. We could probably spend an hour coming up with a list and we wouldn't even get the list started. So I disagree that it's just a matter of kind of plugging solutions into problems, because I don't think we quite know what the known, or we don't quite know what the solution should be. I think certainly in more complicated delivery models like team-based care delivery, which I'm going to talk about in a little bit, community-based care, long-term care. I'm not sure we know exactly what the model needs to look like that we're trying to implement. And it's hard to implement something if we don't know what we're actually trying to implement. So that's why I don't completely agree that it's simply a lack of implementation. Part of the reason that I think implementation is a bit more challenging than Andre says is that, again, going back to my first slide where I was kind of trying to make light on it, health system processes, they're transformational. They're not transactional. It's not just a one-to-one exchange. So when people compare us to, banking, supply chains, retail, this happens quite a bit. It's not really an accurate comparison. It's kind of apples to oranges because these sectors, they tend to be more transactional. Their processes tend to be quite mature, and it is easier to automate a mature process. They got a low number of data. Their processes tend to be lower. Makes it a little bit easier. Trish Greenhoff has a very good distinction between innovation and automation, and I think a lot of times we're trying to innovate. So we're, in a way, trying to build a plane at the same time that we're trying to fly it. And just healthcare processes as a whole, there's a lot of literature that talks about this. They're often evolving and immature. And again, just looking at a bit of historical work, Lori Novak, I know Christian Noor's done it as well. They've done a lot of really good work on what we visualize a health system is looking like is often different than what work is as imagined. Flip that. What we imagine a health system work to look like is often different than what we actually see in practice. That causes the challenge. And there's a lot of literature. It's interesting that every year we see new papers, but they say the same thing about this. When we implement digital health tools, could be order entry, it could be an electronic medical record, a communication system, users don't tend to use it to its capacity upon implementation. In fact, most of the numbers I see are actually quite low, like 30, 40%, meaning that there's a whole bunch of features that a system could do that we're not using. And I think part of the reason that's the case is that just users have to mature their processes, their capacities, and then they tend to pick up some of the more, the more complicated features. And then just kind of the last one, Enrico Cara had a good paper 10 or so years ago. He talked about the degree of coupling, and all coupling refers to is that almost like the more pieces you're trying to snap together, if you think of a Lego analogy, it makes implementation more difficult. So if you've got, a very tightly coupled system, it might be a little bit easier than a loosely coupled system or a system that has multiple couplings, because you're really trying to fit more pieces together in the latter circumstances. So how do we implement systems thinking and digital health maturity? Let's kind of get down to the brass tacks here. I always say the best way to start thinking about a system is to model it. I kind of stole that from Mark Berg because I think about 20 or 30 years ago, he had a really good saying where he said, before we can automate a system, we have to model it. So I'll give Mark full credit for me trying to kind of steal part of his idea there. The way that I model a system, this is by no means the only way to do it, but this is kind of the way that I've done it. I break a system down into two main components, structures and behaviors. I define structures as, as I say, they're the tangible, they're the moving parts of a system. And I've got some examples on the next slide. Behaviors, this is far more difficult because this is how people, how processes, how rules, how different technologies, how they interact within the system, how they interact with all the structures that are in place. The term that I kind of use for system behaviors, I call them the rules of engagement because you can put the structures in place, they're kind of defined, but how people work within the structures, that's quite varied. And that's what I call the rules of engagement. So if we think about implementation from a structural perspective, I call this big I implementation. This is a lot of times what people, I think, are talking about when they talk about implementation. So this can be things like health IT, AI applications, data. It can be different delivery models, be it primary care, team-based care, community care, pandemic response. It also includes things like financing, governance, privacy models. Those all define structurally. It's almost like the blueprint for how a system actually works. System behaviors, again, this is where studies on implementation become fun. This is what I call small I implementation. And as I said a couple of slides ago, this is what I call the rules of engagement for how people, processes, technologies, how they work within all those structures. The reason system behaviors are more challenging is because they develop, they mature over time. This is where you start having conversations about trade-offs. And just remembering that even though structures may be more, they're a bit more, kind of a bit less time sensitive actually. You put in a new delivery model, the delivery model might be in place for months, might be in place for years, but how the people work within that delivery model, that will keep evolving, daily, weekly, monthly. And that's the thing that I think we really need to pay the most attention to. So, if we go back to kind of the digital health maturity concept, in 2018, the World Health Organization put out a mandate to really, in a nutshell, try to optimize how we implement digital health technologies. It said, again, I tried to highlight in red what I think the key things are. We need to think about implementation. We need to think about scale up. We need to think about using digital health technologies to at a bigger scale, just to basically try to promote equitable, affordable access to health services for all. And based on that, what Tang and some of his colleagues did was they developed a digital health maturity meta model. And I'm going to show it to you on the next slide. And it's got kind of 5 digital health foundations and 5 digital health maturity stages. And this is the model that Tang et al. Came up with. And again, you probably can't read the text on it. It's very, very ubiquitous in Tang's book, but across the top, you've got 5 stages. So you sort of start with adapting, you move through controlled, you move through standardized, you move through optimizing, then and only then you kind of get into the innovating stage. And what the model tries to show is that this is kind of this is how digital health tools mature. And then as they mature, they also defined 5 essential digital health foundations. So information communication technology, Internet of Thing infrastructure, essential tools, readiness for information sharing, enablers of trust and adoption, and then quality improvement, measurement, and monitoring and evaluation again. And as with the stages, as you move down, you're getting into more complicated foundations because you're going from just having technology or having tools to, are people ready to actually share information? That's where things like common ground starts coming into play, where it becomes important. Enablers of trust and adoption. Again, trust and adoption are things we've been studying for a long time. And if you go back to, the papers I cited from Joan and Nancy Lorenzi and those, they talk a lot about that stuff. Bonnie Kaplan talks a lot about enablers of trust and adoption. And then as we get into kind of quality improvement and measurements, I mean, it doesn't call it that, but that's really getting into a lot of the learning health systems work. So again, a lot of the pieces that I've unpacked in this talk already, they kind of all come together in Tang L's digital health maturity meta model. So let me give you a couple of examples just to sort of move towards wrap up of how the meta model actually works. So one of the areas that I've done a lot of research in, it's kind of been my main area, is collaborative teamwork. And as I said with the example of the question around design versus implementation, um, I think we don't quite know what the ideal model for collaborative teamwork is. There's a lot of studies on it, but we know healthcare systems need to be more collaborative. We know team-based care is always advocated as a really good model for care delivery, but we don't quite know what it needs to look like. So if we kind of use my modeling approach, if we talk structurally, digital health tools can support teamwork. We know that everything from CPOEs to electronic health record systems to EMRs, they do support teamwork, but what the literature keeps telling us is that they're not optimal. And that kind of makes sense. They're not specifically designed to support teams. We don't design an EMR or an EHR or a CPOE or a chatbot or whatever. We don't design it specifically to support teams, which is probably why when they actually have to support teamwork or collaboration, it does some things, but it's not perfect. The behavioral aspect of collaborative teamwork, this is also quite tricky. A lot of the work that I've done has talked about the need to make trade-offs. We know that when we're trying to design systems to support collaboration, it's an engineering task, but it also has social elements to it. And sometimes marrying the social with the engineering is a little bit difficult. And as we try and think about building systems to support collaboration, collaborative agency, common ground, I believe these have to be key essential blocks in how we build systems. And as I said, common ground can be a little bit complicated. Doesn't happen overnight. And again, that's an example of something that really takes place over time. So, if we kind of just think about collaborative teamwork, I always say it's a system of systems. We're really trying to automate a whole bunch of systems. We're trying to support users, but they're really systems in their own right. The technology, the context, the policies, they're all systems. So we're really trying to automate an evolving system. And, this is, kind of, as opposed to Andre Picard thinking it's an implementation problem, I think at least for the time being, I hope it changes one day, but I do think for the time being, collaborative teamwork is a design and evaluation and training problem, not quite an implementation problem yet. I think if we figure out the design, we figure out, how do we better train people to work in teams, then I think we can probably make some really good leverage on the implementation challenge. So, I tried to map collaborative care delivery, our current state, to Tang's meta model. This is not an exact science. This is really more like an art. I think for the digital health maturity stages, I put it about here. We're definitely not standardized because most places do their own thing with respect to team-based care and collaboration. There are some standards in place. So I said we're kind of on the end of controlled, moving towards standardized. For the digital health foundations, I put it almost on the line between essential tools and readiness for information sharing. Because as I said, we do know that different types of digital health tools, and I think AI, I think chatbots have really good potential for supporting collaboration. We just need to figure out a little bit better how that will actually work. And I think once we kind of flip that switch, we can move from essential tools into things like trust and adoption, and just really working on how do we now focus on using these tools to help us develop common ground. All right, so the last example I'm going to talk about is artificial intelligence. AI is not my main area, but I'd be remiss if I didn't do a talk and mention AI because people would probably think I'm not doing my job. This is an article that I found really interesting. I was probably bored during the pandemic. I was reading anything. So I came across this article in the MIT Tech Review that talked about all these different AI models that were built to support COVID, help manage it, everything from physical distancing to, tracking people on airlines. And the main point of the article was none of them helped. And it doesn't mean that the models were bad, but rather we really don't know because you had all these standalone models that were built that weren't connected, and we don't really know how well they may work if they actually were designed kind of to their extent. So, not picking up on that directly, a couple of years ago, Dylan Crimes, Francis Lau, Simon Minchell, a student from McEwen, Michael Manaru, and myself, we did an umbrella review on AI quality standards in healthcare. And I'm not going to go into a lot of details about the review, but the main things that we were trying to figure out was in systematic reviews of artificial intelligence studies, how many of them are using existing standards? And it could be ethical standards, data standards, just known standards. And how many of the studies were actually using some type of a life cycle? Because, if you look back at Tang's digital health maturity meta model, it's basically, it's a roadmap. It's a life cycle. It's not perfect, but it says as you move through digital health maturity, you go through stages. So we were really curious as to when people do AI studies, they develop AI models, are they using some sort of a staged approach? And our interest was also just recognizing, as this says, that AI is a bigger system. It's not just a technology; it's got clinical, societal, organizational, political, and other aspects. Um, I was a bit surprised, but then when I think about it, I'm not surprised. What we found was we had about 33, I think, studies ended up making the umbrella review. Most of the AI studies in the review mapped to the first three stages of a life cycle by Van de Sande review. So basically, they had a five-stage life cycle, but it starts at stage 0, so there's only 4 stages. So it starts kind of with problem identification, model development, validation, and then really 2 types of implementation. Like, have you done any clinical testing? And then have you done bigger societal implementation? And I was surprised, but I probably shouldn't have been. Most of the studies were actually in the very early stages of the life cycle. So I think, we could classify those AI studies as immature studies. They may have had a problem identification. They probably built a model. They may have validated it, but they didn't move beyond that. We found 4 studies were in the clinical testing phase. 7 said they were in the implementation phase, but they weren't really clear about, whether or not the tool they developed, the approach they developed, had been adopted into clinical settings. So we didn't really know what the implementation ended up doing. And one of the key takeaways from the paper was that there were so many different life cycle terminology and just life cycle approach. I think 60 was the number that I remember that we saw. It made comparative analysis really difficult. So again, the messaging from that is really, use a life cycle. Ideally, if we could use the same life cycle, it helps because it really enhances our ability to compare across cycles. But, again, the other main takeaway is really, we really need to try to get AI research scaling up into a more mature state. We got to get it out of standalone models that are really removed from the reality of society, clinical settings, and all those types of things. All right, so just to wrap up with a bit of discussion and leave some time for questions. Hopefully I've kind of given the notion, given the idea that health systems, they're all part of an interacting systems. Sometimes we build something, we implement it, we test it, we find things don't work as well as we wanted. We get upset. That's normal. Like, reassessing an implementation, it's not really a sign of failure. I think it's a sign of progress. Nobody likes to fail, but that's just part of a learning health system. As we think about designing technology, and this is where I think HINF, you folks are in a great opportunity. We've got to make sure that we're developing the digital health capabilities and competencies in people, all end users, along with the technology we're trying to develop. Having technology that's 100 miles ahead of the people isn't going to do us a lot of good. So people and processes have to mature and evolve too. And as we think about implementation, research, implementation studies, I think it starts by getting the system model right, using life cycle, maturity model driven design. That's always a good first step. And just for a couple of last points, as you think about implementation, just remember that big I and small I, so structural and behavioral, they're both important. I might argue that behavioral implementation is more important, but they're both important. And just as a couple of questions to put out, the thing that I always think about, thing that keeps me up at night, is just trying to appreciate the notion that teams are transformed over time through technology. And as we think about, all the digital health tools that are out there, I think AI has just a phenomenal opportunity to really enhance collaborative care delivery. As I said, I think chatbots have a lot of potential. The question that I really ponder is how do we get machines and humans, working together as a robust care team? And just last thought, just remember the past can teach us a lot. Early versions of Ted Shortlift's biomedical informatics textbook, Joe Nash, Paul Gorman, Bonnie Kaplan, Nancy Lorenzi. There's a lot of really good lessons in those papers. So, don't be afraid to read the stuff from 25 years ago because you'd be surprised what it can teach you about what you're trying to do today. So that's the end. If anyone wants to write to me offline, I'm always happy to have conversations, and I'm happy to take any questions now.